and keep on with us. You will never regret. Now it's my pleasure to introduce my dear friend Francesco Serino from Emirates. He is going to introduce his experience in HIVO.
Hello, a good day to my friend of the Egyptian Venus Forum, and thanks again,
Please play the video.
for your kind invitation to this precious meeting. Hello, a good day to my friend of the Egyptian Venus Forum, and thanks again, Ayman, for your kind invitation to this precious meeting. This year, for the first time, I am attending on remote, as impossible to come, but I promise I will be there next year. What I want to present today, it's an occasional to this distinguished audience. I don't need to restate the importance of the saphenous vein anatomy, but I want to remark why in the history of medicine we decided to sacrifice this vein. And this is important because, as you know, saphenous vein is the preferred bypass material for peripheral bypass, and actually now it's preferred according to the best CLI trial. It's useful for coronary artery bypass, can be used as patch materials for other arterial repairs and segment bypass in general, and dialysis access construction. What was this necessary sacrifice of the saphenous vein cannot justify the transformation in the lucrative extermination of saphenous veins in the name of business and gaining of money out of it. I just give you an example, a study I've done on retrospective analysis on consultation performed in the last 2 years, 351 times for second opinion, where people were coming to us asking opinion about their indication given by other hospitals for saphenous vein ablation or saphenectomy. Unfortunately, 84% of those cases, we found negative results for the necessity of any kind of intervention in the venous system. And most of these cases also absolutely no evidence of venous insufficiency. To the less experienced section of your audience, I want to remark what is the origin of varicose veins. Once we believed the valve incompetence was the etiology, but this is no longer sustained. Now we think more and more about the venous and lymphatic system synergy, which is disrupted by several factors. Most important is overweight, gait abnormality, and more rarely, a congenital valve disease of agenesia. More and more we see varicose vein forming after unnecessary or inappropriate saphenectomies. Why do they form? There are consequences of deviation of the venous blood from the orthodrome way by a leaking point or reflux point to a point of re-entry in the orthodrome trunk. This is creating a pathological shunt. Then the dilatation of the vein, which is varicose, the consequences of hypertension, which is originated by this shunt. And the great paper from Professor Giannesini depicted well these shunts and divided them in 3 types. Type 1, when the reflux point is in the deep system, and the entry point in the saphenous system, or in saphenous system and tributary system. Type 2, when the reflux point is within the saphenous vein system and the entry point in the tributary system. And type 3, when there is a deep vein system exit point and re-entry point directly in the tributaries. Natural consequences of the hemodynamic theory of the varicose vein formation is the hemodynamic Taylor surgery, of course, which was originated many, many years ago by Franceschini, and it is called a Shiva technique in 1 or Shiva 2 in 1 or 2 stages. according to the, of course, the shunt time. Now, from that, we in the latest years, we became to this concept of saphenous sparing surgery. Why? Because through a different technique, which is now endovascular most of the time, we can perform the closure of the reflux point without necessary sacrifice the rest of the vein. Although the tailored therapy is not a new concept, it started in the Roman age, and actually with in the first century before Christ, Cicerone, which was one of the members of the Senate of Rome, which was affected by varicose veins, he was thinking to resolve the problem of varicose vein just covering them with a long dress and going to the ankle. And this is the cause actually of the change of the fashion at the time, because before, if you see on the left, the Romans used to have dresses which were uncovering the knees, and that's changed after the Cicerone necessity because of treating of varicose veins. So now this concept of tailored therapy in the saphenous sparing surgery, it's well suitable with the current techniques, which is laser radiofrequency or sanoacrylate seal, where you can apply the action in the restricted area. It's not certainly possible with surgery or with foam, and this is why this field offer an incredible opportunity. And since the very beginning, as you know, because I presented last year in this same meeting, I'm starting to use the sonotherapy with the Sonovein system. And this is exactly the ideal technique to apply in a non-invasive way and extracorporeal way as saphenous sparing therapy, reducing the energy application to the initial part of the vein insufficiency. No catheters, no chemical injections, and no incision are necessary. As you all know, this technology works leading to waves which are delivered in a conic way, where the tip of the convergent point, which is the tip of the cone, is the point in which the energy exceeds 85 degrees, so therefore inducing thermal ablation. This is not happening at the level where the waves transit the skin, because at the level the energy is much lower. So for using this technique, which is robotic and is guided by ultrasound, you really need to have high ultrasound skills. So as I said, at the tip of this wave cone, or the convergent side of the cone, you have energy enough to induce thermal ablation. The thermal ablation which is induced is similar to the one you can induce with laser radiofrequency. Because basically you have necrosis of the vein wall and adventitia, and ended in thrombosis and occlusion. Now, this occlusion was meant to be stable. And this is the core of this presentation, and which is focused on my learning curve, which are the 16 patients we had performed together with the technician of the company in order to get acquainted with the technology and the machine. As you see, most of the cases were very saphenous vein, 2 cases anterior accessory saphenous vein, and 1 case lesser saphenous vein. In any case, from the beginning, I decided to use this technology in saphenous spare methods. So just applying the energy in the first 5 to 10 centimeters of the vein. And this is when we find the surprise, actually, at 1 month follow-up. When we find in 4 cases over 16 that we had failure of the intention to treat, basically closure of the vein, but we found restoration of the saphenous vein function with the abolition of the reflux. Well, seeing that, then I said, okay, that's probably it's due to inadequate technology or experience we had. And I wanted to see this also in other cases with other techniques like the Venasil or radiofrequency. In the laser, I still have not used a saphenous sparing technology. And even in these cases, in one of the 12 cases with Venasil, I found the same concept, so the opening of the vein and continence, residual continence, and in one of the 30 cases of radiofrequency, same thing. In general, there, I must certainly say this is not a prospective trial, this is not a controlled trial, so it's only observation. But certainly what I can tell, and I'm sure I'm not going to be wrong, is that using a saphenous sparing concept, so concentrating the action of our technology to the first section of the vein may lead to insuccess, meaning that the vein can recanalize, but in some cases we gain recontinence, so we gain new function of the vein. So we should actually study and try to understand how can we intentionally achieve this result. Let me show you one of these cases where we had a type 1 plus N3 shunt, where we gain restoration of the function of the saphenous vein. And this is a case in which the treatment was intentionally given to anterior accessory saphenous vein and greater saphenous vein in the beginning. And that follow-up, what we found is closure of the anterior accessory saphenous vein and continence of the greater saphenous vein. In this case, no treatment was performed in the tributaries. This is another case, a very important case on a young guy, actually Egyptian. He had a very severe venous insufficiency with a huge number of varicose veins and edema. Both cases related to insufficiency of the saphenous vein. So I discouraged him. I wanted to treat him conservatively, but insisted he wanted to be treated by sonotherapy. So I started treating the origin of the perisaphenous vein. As you can see, immediately after the treatment, we had the successful closure of the proximal tract of saphenous vein, and in both sides. After 1 month of follow-up and after foam therapy for the tributaries, we found this result on the right leg, total occlusion of the saphenous vein and tributaries with excellent results. On the left, excellent clinical results, but again, regaining of the patency, so the treated tract was reopened, but at this time continent, probably because of closure of the re-entry point with the foam in this case. So in summary, I say that IFU or sonotherapy is a treatment of varicose vein, very exciting and innovative, of course, and requires high skill in ultrasonography and proper training. Now, what we found is an observation of unexpected clinical success by what we could consider probably technical failure according to the current scheme. And this is leading to an interesting area for research. And certainly this is linked to the idea of the saphenous sparing technology, whatever the technology, either sonovein or laser or radiofrequency or density. And so we also need to think about the new category of clinical success, because in this case, the clinical success is there, but with saphenous sparing endovascular techniques, and actually we should try to change the intention to treat them, try to understand how to lead to regaining continence or regeneration of the saphenous vein and not bleeding. We need to understand how to get to the point by intention and not by occasional finding. In this case, IFU is suitable and is certainly adapted to the hemodynamic tailored therapy, but it's not for all. And to conclude, as a take-home message, I would say, as Churchill says, and as Sergio Giannesini often repeat in his talks, that we don't have to be discouraged by failure. So, because success consists of going from one failure to the next failure without losing our enthusiasm. Thank you so much. I hope to see you next year. Thank you.
Thank you, Francesco. Now, as they say in the song in the Premier League, you will never walk alone. I am honored to have a gynecologist with us today from Romania. I'm honored to introduce Dr.